Hello everyone, this is Dr. S. Meenakshi Sundaram, Consultant Neurologist, Apollo Specialty Hospitals, Madurai. Today I am going to brief you something about women with epilepsy. The first focus will be on pregnancy and epilepsy. Now, as doctors, when we face a person who just comes and tells us that, Doctor, I have just been married, I want to get pregnant. Or later they come and say, Doctor, I've been married, now I want to conceive. Or they come and tell you, Doctor, I am already conceived, what should I do? I am taking this medication for epilepsy. So our focus is trying to find out what to do for these women in the next few minutes. So the first is that whenever a woman is in a childbearing age, the antiseizure medication should be appropriately chosen. We all know as doctors that some medications have got the highest teratogenic potential. The classical example is valproate in women with childbearing age. It may also have other side effects, but the important one is that it may increase the risk of fetal malformations. Of course, many medications can do that, but when we choose our appropriate agent in a preconceptional time itself, we would be quite safe in recommending pregnancy to the given person. So first let us ask ourselves this question, are we in the right track in terms of choice of antiseizure medication? In the choice once we have chosen, we should be on the right track in telling ourselves that the dosage is appropriate. So preconceptionally, we need to teach women the right things. For example, drugs. And very importantly, it's a good practice to ask them to go for monotherapy. Many patients would come and see us while on polytherapy. Try to convert them into monotherapy as much as possible. And then there are women in childbearing age who would like to use contraceptives. They may be on antiseizure medications. So we need to be aware of which of these medications are enzyme inducers and which are not. This is important because many enzyme inducers may actually reduce the efficacy of the oral contraceptives. This is common with many anti-seizure medications. So it should not become a contraceptive failure and a disaster in the family. So you should really appropriately counsel them, have a look at the medications and give them the appropriate choice. And there are a few patients who may require more than one medications. Always they must be under your follow-up, and we must be appropriately telling them the proper advice, especially when they have decided to go for conception. The lowest but the most effective dose is what should be chosen for the given patient. I remember my own mother who would go to a sari shop and say, give me the cheapest and the best one. I always wondered, how can something be cheap and best? But then that's an ideal combination for an anti-seizure medication. It should be good in terms of efficacy. It should have the lowest potential for adverse effects. Then once they become pregnant or they have come only to you during pregnancy, the first thing is that many of them are mortally in fear. What's going to happen to me? What's going to happen to the child? Now, when you look at that, the first thing you must tell them is that the common things we should be worried is that will there be any chromosomal abnormalities? Fortunately, epilepsy is not associated with a higher instance of chromosomal abnormalities. Anti-seizure medications, yes, they might induce the risk. So how should we counsel them? Let me tell you a better way. When you look at the literature, it says around 4 to 6% of people can develop problems because of epilepsy and anti-seizure medications. What is this incidence in the general population? It's around 2 to 3%, right? So instead of telling them that, look, the incidence is so high for you, and sometimes telling them 2 to 3% become 4 to 6%, just doubling the risk, that's a negative way of putting it. Let us put it across telling them that, look, you have a 94% chance of having a normal baby. Especially so if the anti-seizure medication choice was right, it was not a polytherapy, it was a well-planned pregnancy. What is well-planned pregnancy? A woman who is married should be counseled to take folic acid preconceptionally. I often tell my patients before they get married, you start folic acid. In fact, if you meet another person, if you're going for a wedding of your friend, instead of giving them flowers and bouquets, you might as well give a pack of folic acid as gift. That'd be a better gift for them. So preconceptional folic acid is very important. Most of the times, when a patient becomes pregnant and goes to the obstetrician, a good 6 to 8 weeks is past the time, at which point of time much of the neural tube has already formed. So at the same time, tell them that too much of folic acid is also not good. Higher doses sometimes have been associated with adverse events. We don't want too much of something. And keep them in the positive frame. There are people who have become pregnant when on more than one anti-seizure medication, 2 or 3. They already become pregnant. Don't panic. Do not try to stop the medication and suddenly convert them to monotherapy. It's not required at all. Once they have done that. Leave it like that. Explain to them. Ask them to be positive. There are certain anti-seizure medications where we may need to actually alter the dosage during pregnancy. A classical example is lamotrigine. Lamotrigine may need dosage adjustment because the levels fall during pregnancy. Another medication I can think of in the similar manner is levetiracetam. Sometimes the dosage of levetiracetam may have to be hiked during pregnancy. So also oxcarbazepine. Some medications they do not require any change. The classical example is the age-old carbamazepine. This does not require any big change during pregnancy. In the first trimester, women should be aware of the potential decrease in the drug level due to extraneous factors like nausea and vomiting. So that they may actually bring out the drug. So tell them to take an extra dose whenever it happens. Adequately counsel them about the need for good sleep, because sleep deprivation, we all know, is a potential trigger for recurrence of seizures. Emotional stress is something we need to address. When possible, the drug level should be monitored. This is recommended for most anti-seizure medications, but practically speaking, is it really possible, especially in a country like ours? May not be possible. So in that situation, if you choose a medication which requires the least potential for change, as I said, for example, carbamazepine preconceptionally, it's good. On the other hand, if you choose a medication where the alteration is required, we'll make the alteration without looking for drug levels. The classical example I mentioned to you is lamotrigine and sometimes levetiracetam as well. And preferably do not mess up with anti-seizure medications throughout the pregnancy. Throughout, do not touch them. Once they have delivered, you can always do that. And monitoring of fetal growth is very important. Most anti-seizure medications, fortunately, do not touch that aspect. But sometimes, drug like topiramate could do that. You should be aware of that. Let us say you are encountering seizure for the first time in pregnancy. What would you do? Now, an ideal agent to do in this situation would be actually levetiracetam. Before, declaring them as epileptic, let's also look at certain provocative factors peculiar to pregnancy. The typical ones are eclampsia of pregnancy. We are all aware of that. And once they deliver, anti-seizure medications may have some sedative potential we'll all be aware of. Especially we'll be thinking of their excretion into the breast milk. Fortunately, studies have shown that this concentration does not induce much problems for the infants. In the postpartum period, women should be adequately counseled about having a good sleep, because sleep is going to be deprived because they may be actually be feeding their mother, the children. We should also be aware of certain risks which epilepsy could pose on pregnancy. For example, the incidence of eclampsia and preeclampsia is high in women with epilepsy. So also the chance of premature delivery. Hemorrhages are more common in women with epilepsy. There is also a chance of an increased chance of fetal growth retardation and stillbirth and even mortality. Having got all this information in our mind, let's not actually make the patient feel more panicky by volunteering this information in a negative manner. We must tell them that yes, there is an increased chance, but let's monitor it. Once you are under regular follow, we can do much about it. And they may also ask you that if the seizure frequency will increase or decrease during pregnancy. Worsening could happen in some, but not in the majority. May happen in the second or third trimester, but not in the majority. If a worsening happens in the seizure frequency and the seizures are considered by us that they can produce some problem with the growing fetus, maybe we may adjust the medications at that time. With these good advices, believe me, majority of the pregnancies go very well. You may be surprised that more women come out with good outcomes than otherwise. My view and my advice to all young neurologists is to stay positive during pregnancy entire. Thank you very much for the patient listening.